This section of the Critical Care Survival Guide will focus on sepsis in the ICU. First, let's start by talking about a few key definitions. The first is the Systemic Inflammatory Response Syndrome, or SIRS. SIRS is classified as two or more of the following criteria: hyper or hypothermia, tachycardia, tachypnea, or elevated or low white blood cell count, or bandemia. This circumstance of classifications, called SIRS, can be seen in multiple situations, including sepsis, but other situations like pancreatitis or acute MI. Thus, in order to meet criteria for sepsis, you must meet criteria for SIRS, plus have a documented or suspected source of infection. The presence of severe sepsis is defined as the previous criteria, plus evidence of end organ dysfunction. This can be low urine output or acute kidney injury, or elevated LFTs. The presence of septic shock is the previous criteria, plus the presence of persistent hypotension that is unresponsive to an adequate fluid challenge. And finally, multi-organ dysfunction syndrome is classified as the occurrence of multiple failing organs in the setting of very severe sepsis. This is obviously associated with an increased mortality. So now that we've identified our patient with sepsis, we need to talk about the management. First part of management in sepsis is source control. The second is resuscitation. We'll talk about each of those individually. So source control focuses on a couple of key parts. The first is identification of the source of infection. So this may include drawing blood cultures or urine cultures, whatever's most pertinent to the history of the patient when they presented. You also want to obtain targeted imaging when appropriate. So a patient presenting with an acute abdomen should get a CT to evaluate for potential intra-abdominal process causing their sepsis. Second part of source control is source management. So this means giving targeted antibiotics to your source of infection within the first hour. And then if you have any abscess or something like that, it really needs to be drained. Let's move on to resuscitation.
Hey, Dr. G.
Yeah.
Hi. I'm Graham.
Hi, Graham.
I'm one of the new interns here. I don't even have a name badge or white coat yet.
Okay.
You're a little intimidating. I've got a patient in 2313.
Okay.
Pyelonephritis, red hair.
Okay.
Yeah. Blood pressure, not good.
Okay. Have you given her fluids yet?
Fluids. No.
Okay, let's start with fluids. So the first line of resuscitation is always fluids, fluids, and more fluids.
You okay with that?
No.
Okay.
Initial fluids, for your initial fluids, crystalloids are preferred, so saline, lactated ringers are all reasonable. If you have a patient who's severely hypoalbuminemic or has received a lot of fluids, you could consider alternating or giving albumin preferentially. You want to make sure patients receive an adequate fluid challenge at this point. We typically think of that as being somewhere from 40 to 60 mLs per kilo. So for a 70-pound guy, this is going to be 3 to 4 liters of fluid in their initial resuscitation.
Fluids are in about 5 liters.
Okay.
And no different. She's blowing up like a balloon, blood pressure still stinks.
Okay, it's time to place a central line.
Central line.
Yeah.
Like in her body?
Yes, inner body. So a subclavian line or an internal jugular line is preferred.
Good news.
Yeah.
Line is in.
Congratulations.
No problems, no complications, no pneumothorax. Ship shape.
Okay.
Bad news
Yeah.
is the blood pressure is still not good.
We need to improve our perfusion and maintain a reasonable mean arterial pressure. So our initial pressor in septic shock is typically norepinephrine, and then we tend to use vasopressin or dopamine as second line agents.
Got it.
Okay. Once you have these pressors started, you're going to titrate to a mean arterial pressure of 65.
I'm back.
Yeah.
You're actually not as intimidating as I first thought you were.
Good.
But our patient is still not doing so hot.
Okay, what's
3
going on?
vasopressors, urine output's dropping off. Nurse and I are just kind of freaking out.
Okay. Did we check a central venous O2 sat yet?
Central venous O2 sat.
Yes, this is drawn directly off the central line you just put in and will
Okay.
help us to decide how well this patient's being perfused.
All right, we'll get right on that.
Great. So central venous O2 sats suggest cardiac output and tissue perfusion. For this reason, we want to target a central venous O2 sat greater than 70%. If your sat is less than this, you would consider transfusing to achieve a hematocrit of 30, or if you're already at a hematocrit of 30, consider starting dobutamine to improve cardiac output. Couple things about this. So what happens when you have a low oxygen saturation? It suggests that your tissues are fully extracting oxygen, but the blood cells that they're receiving are low in oxygen content. So they're avidly taking up oxygen, and when the blood returns to where your central line is, it's lower in oxygen saturation. The converse of this is actually probably a more ominous sign. So if you see a central venous O2 sat of 80 to 85 in a patient in severe shock on multiple pressors, this is bad. It means that blood, although it's circulating, the blood cell or the peripheral tissues, as the blood goes by, have pretty much given up. So they've decided to convert from aerobic to anaerobic metabolism, and typically you have a rising lactate at this time. So let's recap what our management is of sepsis. The most important thing first is to identify that your patient has sepsis. Once you've done that, you want to move on to source control and resuscitation. Source control, again, means targeting your source or identifying your source of infection and targeting antibiotics for the appropriate source of infection. Finally, for resuscitation, fluids, and more fluids. It's not unusual for a patient in the ICU to receive anywhere from 8 to 15 liters of fluids during their resuscitation. After fluids, you're going to move on to vasopressors, and then ultimately central venous O2 sat to help improve tissue perfusion.
Dr. G,
Yeah.
good news. 2313,
Yeah,
doing better.
great.
She's down on pressors. We've weaned off really all of them. O2 sats are looking good. I think we've saved the day.
Congratulations, Dr. Graham. I think you saved one.
Go get my name badge.
Great.
All right.
This concludes this section of the Critical Care Survival Guide. Thanks for watching.